was a 76-year-old male with peripheral arterial disease, multiple cardiovascular risk factors, prior angiogram, and we're going to go ahead and look to see what we've treated in the past, which was a common femoral profunda femoris artery lesion, which seems to be recurrent, while our SFA distal SFA popliteal stent is hopefully wildly patent, but he's still now having recurrent symptoms a year ago already. Okay, wow. All right. So we had some good durability, but not enough. And that's why we may want to be taking one look at that common femoral artery and reevaluate. Little pinch. I know we got bilateral common iliac stents, which may prove somewhat challenging to get up and over, but we'll see. Hopefully not. All right, I know he's got a bit of a tortuous iliac. There we go. So we'll go ahead and put the 5 French micropuncture introducer, Benson wire, 6 French sheets, Omni flush. See if we can get up and over with an Omni flush catheter and a regular non-stiff glide wire. If not, we'll switch it out. I definitely think we'd like to do a 7 French sheets, Lori, for the up and over, so we could potentially little push. Let me know if you're having any pains there, okay? Good. All right. All right, that's good. Just, yeah. Don't move. Okay, so that is the stent that we put in from before. Probably take a look at it, but it actually is looking not too bad. Okay. We're just going to go back up here. A zoomed up run of this area here. I think we're in a good, yes, perfect. Don't move, don't breathe. Hold your breath. Okay, so this is really a lesion that is a complicated lesion that almost looks like it goes towards the bifurcation, the profunda and the proximal SFA and the common femoral right there. So we'd be able to land a stent perfectly. And that calcium, we'll IVUS it again to see where it is, but it was more eccentric than not. So do you have a 180 Rosen?
Hey, Kevin, how are you? Yeah, can you hear me?
Oh, who's
Good.
here? Is
Rundback.
Dr. Rundback? Oh, Dr.
Yeah.
Rundback. Okay, you're seeing just in time. Thank you for
Yeah.
coming. And yeah, you can go ahead. So we have a 76-year-old male, multiple cardiovascular risk factors. What you can see here, sort of distal common femoral artery lesion with a
Yeah.
little bit of a difficult up and over. So we're going to get up and over with the 7 French sheath now. Before crossing, we're going to leave this more stiff wire right there at the top, and then we'll try to cross and maybe wire the profunda, wire the SFA through there,
Right.
and IVUS, and then see if we're going to do a definitive stenting. Because, like I had mentioned earlier, we did perform orbital atherectomy in that lesion and DCB, and it really recurred. And he did feel much better afterwards.
Just one thought on that. First of all, a couple thoughts. I mean, looks like from that picture, unlike what I saw earlier, that it actually ends above the bifurcation. Is that, you still think that's true? You have good oblique to see the origin of that profunda?
I'll do another oblique and we'll see. What are you thinking?
Well, that'd be ideal because even though in BMI, with where they cross the profunda with the stent, they didn't really compromise the profunda in most cases. It's something obviously you'd like to avoid. It's Kundal's data, Belgium,
Yeah.
and they have 2-year follow-up now. So, and also it has implications about necessarily where you try to recanalize. I think we discussed you theoretically want to recanalize the profunda side, reserve profunda if possible.
Yes, that's my plan. Definitely preserve profunda. That is one of the main goals is to preserve it, wire it as well separately, and then go from there.
Yeah. And one other thought, if it's really above the profunda before you get a second wire down, and it's really eccentric like that, if you can recanalize on the profunda side, would you ever consider putting down a filter and doing some directional atherectomy to debulk that towards the medial aspect? Take one of the calcium cutting devices and clean that up a little bit before you go ahead and dilate and put your supera. You're probably going to be looking at a 7 millimeter supera.
Yes, I pulled a 7. I'm thinking about a 7.5 actually, but yes, we have it ready to go. Can I get 5,000 heparin, please? And the answer to that, all those answers to those questions are yes. So I would absolutely do that. And you're thinking to hawk down into directional atherectomy down through and into the SFA, not into the profunda. Is that correct?
Yes, exactly. Have a filter down that SFA, and
Yep.
you'll just sort of, keep your cutting, pretty much east, a little bit, a little bit anterior, a little posterior, but kind of pointed all medial there. Just clean up room before you take your aggressive balloon, because you still have to get, just like any superior case, a lot of vessel prep is key. So, you'll debulk that plaque, then you can take a 7 or 8 millimeter balloon, more than you would normally do, understanding you're planning a scaffold. And then, of course, you'll have room to place your scaffold nominally. So,
Absolutely. I'm going to do a nice run here on this oblique. I think this is a very good oblique Lori has for us. And then we're going to, I'd like to wire with a GlideWire Advantage 014, please. Long 014. Don't move. Don't breathe, sir.
yeah, I'm trying to zoom it up here. It's close. It's close,
Close.
but I think
I
that's
see a little channel right there that goes around. And like I said, I've been there before. And right now we're going to be using the specs. You can hold the wire tight there, please. Lori, can you give me a roadmap on that?
the nice
That'll
thing
be
is
awesome.
directionally, your bias seems to be towards the outer side of that lesion, which is nice.
Yes, it is nice. Hold the wire tight. Try to get this catheter. So we're using the 5 French, 4 French
Well, the reason I
specs,
mentioned
actually.
using Hawk is that
Yeah.
you talked about wire profunda. If you are going to consider doing, an extirpative atherectomy with that Hawk, then you probably don't want to wire that profunda yet, so you don't
First.
get wire entanglement.
Yeah, that's right. What do you think about, though, doing some directional atherectomy and the profunda side as well?
Well, I guess let's see where your wire crosses and bring your IVUS down, and you'll have an
Yeah.
idea, how eccentric that calcium is.
Laurie, off this road map, I want to do another one. Let's do a little bit less of an oblique, actually, because I think it's a little bit too overlapped. Let's see if that's a good one. Don't move, don't breathe. I like that. Much better.
Like that.
Okay. Let's pause that there,
Yeah,
road map that one. What do you think, Dr. Rundback?
yeah, you should be able to land this thing super perfectly at that bifurcation, right?
I think so. I think
Yeah,
this
but I do
is,
like the idea of debulking it.
yeah, I agree. Fine. So that wire crosses easily into the profunda. You saw that. Let's see what we can do here. So, Laura, you want to see if we can get a spider filter? Let's say if we have a 6, that might be the best for us. It's a pretty big vessel. And you see that? I mean, this was just minimal torquing of the wire goes right through. What I will say though is that I have an 014 GlideWire Advantage that went nice and easy. And this is an 035 catheter, and I'm not surprised that it's not going to fully cross there with it. That's, there's going to be a shelf there. Okay, so why don't we go ahead and this, all right? And then we'll make our determinations. How's that, Dr. Rundbeck?
Yeah, considering the eccentricity of that lesion with a steeper oblique, it suggests what you're seeing on this view is a lot of on-fuss calcium, which is more anterior. So,
Yeah. So
you're
what is that
probably
changing your plan a little bit, or?
No, I still think that your wire is probably obviously eccentric to the lesion, but rather than being lateral, it's kind of posterior to the lesion.
Okay.
Okay.
Yeah. Fine. All right. So we're going to go ahead and eye this. And yeah, I mean, I think that a 7.5 or a 7.40 or 7.60 Supera just to go in that area. But you don't think we should potentially buddy wire that profunda?
Well, I mean, obviously, if you're going to buddy wire, then it shouldn't be a problem to have a wire outside the supera. So
Yeah.
I don't think it'll entangle. Should pull that fine.
I mean, it should be okay.
You don't need a buddy wire for the stenting part per se, necessarily. Not with this appearance. I think.
Yeah, and I think also having been there, done that already with this case, we probably don't need to. I think you're right. Okay, so we're going to get the IVUS catheter to go in. I'm also, about the filter. Did we find any filters? Yeah. All right, so we'll have to check our inventory a little bit more on those spiders. And
And if you're unsure about the directional atherectomy, what you always do is take a small blow on, make some room and kind of, repeat the angio. See what response you're getting, how that plaque is shifting.
Yeah, exactly.
You mean, if it's shifting well and away from the profunda, then you just be aggressive, push it out of the side, and still get nominal stent expansion. That'll just be now wall calcium.
Exactly. No, don't forget, we did do orbital atherectomy because we did this case transradial probably about 9 months ago. Right. And here we go. So let me you want to come off the roadmap, that's fine. Yeah. We are about to cross, and
that's an interesting point. So all your intimal calcium should be done, right? So now it's just
exactly,
and neural calcium.
Right.
So maybe, although I like that extra atherectomy, that you may not gain much. This may be more of a plastic response. Yeah.
Exactly. That's what I was kind of thinking. And I think that maybe it'll just, we got to get a really good sizing of the vessel to get our best result and go as big as possible. So what we're gonna do is we're gonna go ahead and get some color flow on that. Okay. Chroma flow. Good. Let's do a record. And if you can, we can always we'll show that after.
Yeah, I see a big image or an inset image.
Exactly. You see the inset on me, and just behind there is going to be the IVUS, and you see Edric there in the background and Angel, and they can wave and say hello as well. And here we go. We're going to do a pullback. This is from the stent. Again, we did a transradial case before. There's a little bit of ISR there, but on our Dopplers, it was triphase. I believe it was good flow in that area. It was just this recurrent common femoral lesion. But what was that? Let's take one quick look there. That's an area. I don't think that's an area of stent fracture, but I want to see. What do you think? Can you see that there, Dr. Rundback, on the floor image? I'm going back now with my IVUS in an area that something.
It's either stent fracture or overlap. There's only one stent. It's not overlapping stents. Yeah, it's got a little fracture.
It looks like a little bit of a fracture there, and then just proximal to that was what I want to do is I want to take one. I'm going to do a quick run with the IVUS in because look at that proximal edge there. Looks like you didn't see it on the initial angio, but
it's been a while since I looked at this, types of grading of fractures and number. But one is just a little break. Two is when you sort of see a break with some separation. Three is a spiral fracture with multiple breaks in the struts. And then four, I believe, separated or something along those lines.
Yeah, so we're going to take a look at that after we finish again because it almost looks like it's a small fracture in an area. And would you say that's an area that gets a lot of torsion? Stop that IVUS for a sec. We're going to go back up now and then want to relook at that common femoral area. So that may get, now that we have an up and over approach, again, we had to do this transradial. Just move your head for a sec, Angel there. Good. Go back to live, please. Go back to record. Good. So we're going to go through now here. I'm going to hit the common femoral just starting right about now and paying close attention. We're luminal in our crossing. And I don't know. We're beyond it already. So I'm going to do that again. So look, if you look at where the tip of the IVUS is here, because I think this is going to be very crucial for what we want to do, Dr. Rundback, is I'm going to do another run here. Okay. We see exactly, I'm going to mark on the screen exactly where we are dealing with.
Yeah, we have that nice feature on the this GE that you actually, it's got an annotation on it.
Yeah, I'm just gonna do it on the Tim just because it's right in front of me, and the other one is kind of on the side. So right here is the lesion.
Can you hear me?
Yes, we can hear Dr. Murphy here's also online as well. Look at this, guys. We're right here with this common femoral. What do you think? Can you see the IVUS image well? Let's mag up more on that camera.
Not too well.
Not too well. Okay, so we're gonna get it closer.
Looks like you have what they used to call a coral reef plaque.
Yeah.
Yes.
Well, how would you define that?
Popcorn calcification.
It's usually the posterior wall, and it sort of grows like a tumor. It's not concentric.
Yeah, what I'm going to do is I'm going to have you guys, let's bring that TIMS and the IVUS closer together to get camera, because I do want a second set of eyes on this to see if we should do directional versus just balloon and stent. Because to be honest, we already did some atherectomy. All right, guys, you can see that better now, right?
Yeah, is it sort of upper left?
Well, look at this. So here's the distal to the lesion we are right now at the SFA. Okay. And now I'm going to be pulling back, and right here, I'm going to show a image there on fluoro. You could see where my drawing is. That's where the IVUS is right now. That is part of the lesion, and then just proximal that is where it gets tight for a brief second, and then reopens right there. So we have a reopening right here. And I would do is really measure the vessel here. Can we tighten that picture up, Edric?
It's a little hard to see, but I don't know.
So this picture here, this one.
Yeah, I don't really see luminal calcium there. I think that the orbital
Exactly. That's what I'm saying. I don't think it's luminal calcium. I think it's just eccentric. What would you say?
Yeah.
So what I'm going to do is I'm going to measure it here in the SFA because that's the best place that we're getting an image right here, because we got to get a little bit of a better picture here so we can get and all of this stuff can easily be edited, guys, out of the podcast. So that's what's beautiful about doing it. Push it forward a little. Yeah.
So Dr. Murphy, well, Dr. Herman works there a little bit. Can you talk about some of the unique features of that Summa balloon, how it can be advantageous?
Okay, see right there.
I appreciate that. I'm not sure the Summa, we have the baloney balloon cleared now, which is up to 4 millimeters diameter. It does have proximal injection ports, so it is useful for doing real-time balloon placement, pre-procedure, use it for lesion crossing, diagnostic angiography, angioplasty, post-angioplasty, completion angiogram, all in one. But I'm not sure it's really that applicable in this case, because you're probably going to want a minimum of a 5-6 diameter at least when you're done. So it might not add much value in this location, don't you think?
Keep going.
Well, I mean, obviously you'll make bigger balloons, and in this case, it's closer to the injection port teeth. So,
right there.
But I would not be against taking a 4 millimeter Summa, because that initial predilation, seeing what the lesion response is before we go to our definitive predilation. Any other nice thing Summa is you balloons there, you don't have to move it, you inject it, you see it right away, and can make further decisions.
Yeah. I mean, I think that's a good idea. Sometimes angioplasty in the CFA works surprisingly well. I'm not sure about this case because it looks like it's a little eccentric, but I'm kind of a big fan of angioplasty in the CFA. We used to get a hard time about leaving stents because there was an idea that they somehow adversely affected surgery, and that's possibly true in the case of some stents, but I'm not sure it's that critical an issue today.
Yeah. And we were talking about the VMI data, which is by Koen de Loos, who's a Belgian surgeon. So obviously that helps because, certainly surgery endarterectomy is the gold standard, but his data out to 2 years.
Can I get a 740 balloon, please? Sorry, guys.
He's got about an 85% primary patency at 2 years with, putting in Supera stents. Compared to surgery is about 92, 93, but the rate of wound infections, seromas, and other local complications essentially eliminated. And most importantly, in his videos of this, and I'm friends with Koen, is that it is actually not adherent. So the time of surgery, you have to go back in, it peels right out. And finally, it doesn't prevent access. We have numerous cases now. You access right through the Supera stents. So we've been using that VMI data kind of as gospel and leaning heavily towards scaffolding those common femorals.
I also want to make one comment about that. Not only accessing it, but closure has been fantastic using the Visurum Kelt device in these lesions. We've had great success with that.
Now, the other vessel that comes into play, it's not in play here, but the proximal profunda, I always thought was well.
I don't think it will.
And that was something that the surgeons used to try to discourage. But that's a vessel that, to me, like in contrast to the SFA, which angioplasty sometimes can be challenging, the CFA and the proximal profunda, I always thought responded quite well.
Yeah, absolutely.
So I'm going to try to cross this with I measured a vessel to be about 8. So we're going to go ahead and try to predilate with this 7 balloon. And again, we did perform orbital atherectomy in the past 9 months, and we did have a good result. But again, this is recurrent, and we want to go ahead and do definitive stenting of this lesion. I think we want to optimize the vessel prep, as you said. I'm going to try to get up to about an 8 millimeter balloon. So if you want to pull an 840 balloon, we can try that, and then we'll go with the 7.5. That'll be fine, because once we have the lesion effaced, we should be okay.
Yeah,
okay, sorry to interrupt, guys.
Always nice to go a little bit bigger with the balloon, then you're going to deploy selected Supera. So yeah, I think
this actually landed this went through perfectly, guys, by the way, just so you know. So that's awesome. So we're going to go up here we're probably, I'm going to go just slightly lower, right here. So we'll dilate this. We can go up to 12 here. That's why I like 12. Nice and easy.
I'll let Dr. Murphy continue moderating from here because, as you know, I got to get
Yes,
in.
you have patience. Dr. Rundback, it was great to speak with you, and thank you so much for your knowledge.
Yeah. I look forward to seeing that final result. Thank you.
Yeah. All
Thanks,
right.
John.
You can take that down. So we're going to do, and I was mentioning before for any late entrants that you can go up, that we initially treated this with orbital atherectomy via a transradial approach for various reasons. Beautiful. Okay, take that down. We're going to do a run. I'm going to probably do an 840, or if you have an 860. If you have that, that's great. If not, we'll do the 40. That's just fine. Do a run, and then we'll probably use that 7.5 Supera, and I think we should be good.
How was the distal runoff, Kevin?
Looks like this may have actually, the distal runoff, that's a good question. The distal runoff, we'll talk about in 1 minute. Looks like this may have ruptured. I don't think so. Distal runoff is, well, he had a severe distal stenosis in the very distal SFA and proximal pop, which we showed earlier, which was stented at that time, from the transradial approach. There may be a stent fracture in there. We're going to relook at that. Yeah, keep backing that out.
But just improving the CFA, the CFA is so
Right.
critical.
And he got much better. And then it just recurred. We had a follow-up ultrasound and don't move. And now we're here.
Yeah, all the collateral roots, it got better. All the
Yeah, it's
collateral
much
roots
better.
are very dependent on the CFA,
Yes. And so what we're going to go, exactly. And what we're going to go ahead and do is, can I get a 3 cc syringe, please? Yeah, I'm going to go ahead and
Now, I don't recall, did the plaque compromise the origin of the PFA to that amount, or has it sort of moved?
No, I think that we're seeing more flow in the common femoral. I don't believe it's compromised at all. And again, I do have the luxury of having been there, done that in this case here. Let's go ahead. This is where I'm going to stand. If you see those red lines there on the screen, I don't think that that's a big deal there that needs anything. But let's go ahead and we're going to pre-dilate with the 8 and then put that Supera in and should have a perfect result.
Now, your landing zone, you're going to be close to the origin of the PFA, right?
I think we're going to be okay.
Yeah,
I think we're going to be just fine.
A real-time injection while you're pulling back as you're deploying, or you're going to use the red marker?
I'm going to use my red marker. Yeah, the 8. Yeah, let's get the 8 balloon, 8x40 short shaft. Then you could open that 7.5 Supera. I want to talk a little bit more about the crossing catheter that we use. They actually put a little angle on that spec. So we do have Edric from Reflow here. And what are some great characteristics of that catheter there? I just used the standard specs. It's got a 19 millimeter shapeable tip, which was really helpful in trying to direct out 014 wire through the lesion. And it had great body. We had a tough bifurcation, but you know what? Everything moved very smoothly. We're very pleasantly surprised.
But your CFA,
not too much calcium.
Your CFA is a little short.
Yeah, it is.
Could use a little more room. But you're confident that you're not jailing the PFA.
Yeah, I don't want to use that term jailing necessarily, because through that Supera we'd be able to wire it. I was actually thinking about wiring it before, and we may go ahead and do that. Yeah, and that's why I have the 7 French sheath in. Yeah. Keep going.
I mean, but once you deploy your stent, you'd have to renegotiate it anyway, right? You're not going to work around the stent.
Sometimes you could, actually, if you needed to do like a kissing balloon. And that's what I'm going to do.
Usually, if you need to get through the side of the stent,
you can take it down. You can open that.
You can. Through the side of the stent. Yeah, it's pretty easy. And then
Superas can sometimes be challenging, and then it goes back. So what I'm actually going to do is, before putting in the Supera, we're going to go back in with the specs catheter, and I'm going to just use a buddy wire, and then we'll stent with that buddy wire just so we're okay. I think that that's a very safe and a good plan. Give me an 014 command. Give me a long one. Okay. So I'm going to do a quick run here. Then we'll put in the specs catheter, assuming that we're happy with this result, and wire that profunda and then stent the common femoral, and we'll really see the origin that way. I think we're doing okay, and I wouldn't even mind necessarily ballooning the profunda afterwards. Let's say, we could even potentially do some kissing balloon at that time, not to compromise it.
This
But
maybe do like a 15-degree RAO or something, because there's another vessel that's overlying. I don't know if there's
yeah, we may
descending
get that
lateral femoral
once I wire it. I'm gonna try to do a
sorted out.
another. Yeah, let me have that wire. And Lori, do we have any rapid exchange fluoro balloons by any chance? Now, if you were, Dr. Murphy, to want to stent the profunda for some reason, what would you use? Right, you know, I've seen some people talk about some balloon expandable stents in that location to be perfect, but I would probably just overlap it with a short supera as well. We've had some good results in some very complicated cases
Yeah, I
with
mean,
that.
the balloon expandable stents were used in the leg years ago, but when people crossed their legs or had some other external pressure, they would collapse the stents, and so I think they're kind of out. You
Yeah.
could use a
Okay.
short one in the profunda. The profunda is a little deeper. If it's a short one,
We get
it's
that
not going
wire.
to flex that much.
Right.
But I think the self-expanding might be a little more standard.
Okay. So yeah, I
Unless
think
it's a
so.
very focal lesion. You know, if it's very focal and you put in a self-expanding, it might not have enough hoop strength at that one spot to keep it open.
Yeah. Now the wire, which really did preferentially want to go into we're just almost at the origin of the profunda there. It's gonna get one torque. Nope,
Oh,
not
that was
quite.
it.
Let's see. It was, but just flipping back. There we go. So now you see kind of where the real bifurcation is. Can you see that? Lori, maybe you zoom up a little bit more.
Yeah, it's
Just a
probably
little.
somewhere around the top of your second red line from the left.
Yeah, and I'm going to
That
redo
would be
those
my
lines because I'm going to do
guess.
one more run here
You know what
in
you could
this.
do? You could take an O3 or advance your sheath over both of them, and where the sheath stops,
Yeah, you can do
that's your
that,
flow
right?
divider.
Yeah, you can kind of see that. Let's see if it'll go. Little push. Well, it's going to do
One.
one run here. Yeah,
You could
right.
if they're
let's
both
see.
O14s, you could take 5 French and just run it over both of
Yeah,
them.
that's what I had. We may do that again. Let's see if we're going to do a run right here. Don't move it off, sir. Yeah, I think we are going to end up just being at that ostium.
Yeah, you kind of have to. You're not going to get the full
Yeah.
CFA lesion if you don't.
No.
Of course, you could understent it, you know.
I'm going to go from right to right here is going to be our goal. So you can get that supera out there. We're going to overlap. It's just, I want to use a 7.5. Do we actually have a 7.540 by any chance? Excuse me, a 740?
What do you think
We'll
about
go
an
with this.
RAO 45 or 30 or something like that?
I don't know. We could RAO you want to give me a little bit more oblique? I mean, what are we at now, Lori? We're at 30. You want to go a little bit more? Go deeper.
Oh,
That's fine. I'm
that's
down with
pretty
that.
good oblique. That's pretty good oblique.
Yeah, we could do a little bit more. Why not? I think we're going to go ahead with the 7.560. We're going to, pack it tightly. We already pre-dilated with that 8 on the advantage. Yes, please. Do one more run like that. Perfect. Don't move it all. Yeah. Oh, I like that. Dr. Murphy, great idea. Can you pause it right there? Old school. Yeah.
We didn't have any IBIS. We had to sort things out with rotation.
Right. Pause it right there, please. Thanks. So right here, if we needed to do a little bit of dilatation there in that proximal profunda. And obviously we're going to overlap the stent a little bit. That lesion, we're going to pack it just as tight.
So this raises the question about deploying kissing stents.
Yeah. So what I'm going to do this stent first, and then we'll see about the other.
Mm-hmm.
Okay. Pull back a little. There's the edge. So we'll start deploying the stent just a little bit. You have a dry gauze, and I don't mind a little bit there in that.
How accurate is the marker on the stent, and how much foreshortening do you get?
Yeah, great question. So I'm going to start there because I don't mind that right there being a little bit beyond my lesion. And
there it is.
it's
Right?
going really well. Yep. And
Will
how
it
we doing on the hands there?
From the back?
Yeah.
So where you landed is where it stays, but you got plenty of stent length.
Yeah, what I'm going to do is I'm really trying to try to pack it really tight in here. I think it's doing good right now. I'm spending a lot of time doing that to get really tight cells. We thought about lithotripsy also here, but after the IVUS, I don't think it really needed it.
Mhm.
This is really going very smoothly.
So I hear a lot of different numbers about the percent of calcified lesions below the knee, and I guess it's all subjective and it's probably linear rather than a threshold effect. But how often are you finding the lithotripsy to be useful in, say, below the knee or SFA?
Below knee, actually, funny, I have not used it below the knee yet. SFA, I've been finding it quite good. And the iliac's amazing, and certainly adjunctive treatment sometimes is some very, very complicated lesions. Give me 1 second. I'm just really trying to focus on landing this
Take your time. Yep.
perfectly. And I think let's try to pull that out just a little bit. I might actually come off my thing there. One more push. Would have loved the 7.540 instead of the 60, I think. But we didn't have
Mhm.
that size. And
Well,
we are
it
good.
looks like it's wide open.
Yeah, I think we're going to be great here. And then we'll figure out if we want. Normally, you don't need to post dilate this. You back that out. Laura, give me a D-zoom, please. And that's that. That's good. Perfect. So it's
Is pre-dilation your standard?
yes. Yeah, I mean, you got to really dilate these up well. We decided not to perform secondary, atherectomy as the second time here based on the IVUS results. Don't move at all. I mean, we have complete preservation of the profunda. There's a little bit of hang up of contrast there. So I do think it will be worthwhile to let's get maybe a 5040 014 balloon, please. If you have,
Now, are you going to work
I'm
through
going
the
to
stent
dilate
or
that. Yes, I'm
alongside
going to
it?
try. I'm going to try to get it alongside, see how it goes. Because again, when this stent will just some stents you would worry about crushing on the other side. Not with. I don't think I'm worried about that at all with this Supera. So I'm not going to bother doing a kissing. Yeah, this is going to go on the profunda wire, and I think
You're
that'll
not
be it.
worried about crushing because it's an elastic.
Yeah, exactly. Exactly. This will be the profunda, which is a greater than common femoral proximal. Yeah, proximal SFA. You see that lesion just distal in that SFA? That did not show
Yep.
up on IVUS. That was a nothing. That was not a luminal. That's just a piece of calcium that's there, but it was not.
Not
It
flow
looks bad. Yeah, exactly. Not even not full limiting. It was not even appearing stenotic on the IVUS.
Oh,
So, otherwise I could have extended the stent a little bit lower. But
I mean, if you have a severe lesion in the common femoral and you relieve that, it makes a huge clinical difference.
yeah, no, he's going to be great. And this patency is going to, I mean, according to the data, it's, we got 4 years out. It's going to be fantastic. But I do want to just touch up this profunda. I think will be
Mm-hmm. Mm-hmm.
good idea. Profunda's
That's slow.
the left
Slow.
main. Yeah, the flow is good. The flow is so fast through the common femoral now down into the SFA that it's, preferentially going to just fill there because you have the profunda lesion. Let's see if it'll cross. It should cross pretty easily, I would think. And it's not yet. This is an 014 balloon.
Maybe
Okay.
sometimes a little piece of the tip gets just caught and you just rotate it off and it'll go.
Yeah.
If you can get any torque around the bifurcation.
Let's get this wire down a little bit more. That wire tight again. I may need to
Losing wire.
look at our, yeah, we're losing wire. I think our sheet popped up a little. That's what I'm going to guess. Yeah, no, it doesn't want to go through. So, I mean, I could
Do
try
you
it
still have the
smaller.
balloon on there?
Yeah, what I'm thinking to do is, I mean, I want to go with a 5 to be definitive. I got my sheet back down
Can you
nicely.
advance
So let's see.
wire a little bit more with the balloon in?
I tried. It was stuck. It didn't want to
Stuck.
go. Yeah,
Okay.
yeah, we're going to have to
All right.
lose
Well,
that,
that's
unfortunately. That's okay.
yeah, I'm not sure that's the best way to do it anyway,
No, we're not sure. I think that we may actually not even redo it, to be
You put
honest.
down
Give me a zoom.
like an angled, like a multi-purpose catheter.
Yeah, then you can kind of do that.
Try to
Exactly.
select. Yeah, if it doesn't go, it doesn't go.
I'm going to go ahead and try to wire it with this glide wire advantage, and we'll see. I'm not, sometimes if It wasn't meant to be.
Well, less is more, right? You know,
Yeah, sometimes. No, listen, we're good. I wouldn't have minded touching that up if we could, but
it wasn't great when you started, and you know, it's no
no,
worse
now it's
now,
yeah. Oh
but you
yeah.
have a
No,
much better CFA.
exactly. I think it's the common femoral is going to be the key. Sometimes you want to try for 1 minute to be a little greedy,
Yeah, if it's
if
going to
you
give it
will.
to you, take it.
Exactly. I'm
But you
not
don't
sure
want to
it's
make it.
gonna.
You don't want to make a 2 hour. You know, end up with
No,
complications.
I don't think we're gonna need to do that. Do one more run here. See if we should roadmap it. Don't move. Right there. I mean, it looks good. So yeah, I don't have. This is not an angled catheter, so we'll see if we can do any magic. And if so, great. Right there, perfect.
Is the wire angled?
Yeah, I have an angle tip. Yeah, there's an 0.14 glide wire advantage. Yeah, I think it's right there. What's funny about this balloon is it's not going easily through it. So, which,
Is the superior woven?
yes, it's a woven nitinol stent.
So it could just be getting caught in one of the apices where it's sort of
Yeah,
wedging down as the
zoom a little.
tines
Yeah, I was
cross.
just wondering why the balloon. Usually, you can easily slip by there. That's why I was just kind of surprised. Don't move.
It's an 014 balloon.
I mean, that looks so good. We still have a little bit of that hang up of the profunda because I do think it would have been nice if we had some treatment to that. Let me have the specs, put a little angle on it. I'm just curious to see if I can get into that with a glide wire. I would spend like, 2 more minutes or so with that. And then we're just gonna readdress. I want to put that spec to I just want to get a very distal shot of that proximal edge stenosis at the SFA stent. 034. Yeah, let's start off with the 035.
I like that better.
Potentially.
I like that
Why don't
better.
you
It
show
gives
this
you
on the
more
camera there?
body and a better able to use that angle to select.
Yeah. So right now we're using the specs. We have a nice, what would you call that thing that you put there in the end hole of the catheter? That's what was that? That's a mandrel that we're putting in the end hole of the catheter and using it to shape the tip so we can try to get into that angle. Give me a little bit more. Just a little.
You remember the Hanafi tubing? Did you ever use that? You're too young.
No, I'm too young for that. I mean, I'm not that young. I'm 47, but yeah.
We used to, you know, how many years is this ago? 30 years or so ago. It was common to have
Well,
just
glide wire advantage, regular
polyethylene
glide.
tubing. And in some cases, you would fire up the steam and shape your catheter in the middle of the case.
Oh, yes, I've heard about that.
They didn't hold
Sounds
shape very well.
Yeah, sounds fun.
For 5 minutes, and you'd have to take it out and reshape it. Yeah, it wasn't great.
Meanwhile, let's get a 7 French sheath, please, and we can do I think we'll do a Celt. We'll do a 7 Celt. So just want to make sure that we don't get any edge bias there. So now we got this catheter. Now what I want to do is we're going to need to flip the specs the other way, probably.
Is that an angled glide catheter you have?
No, that was the beauty of this catheter is that you can make it. It was a straight catheter we made,
Okay.
But it is
shapeable.
It's shapeable, but the shape is
there. You go.
Now we're okay. Yeah, the shape was working a little bit against us.
And is that a marketed feature of the catheter that's shapeable?
Yep, it is. Yeah, it's a fantastic catheter. This is Reflow Medical specs.
Cool.
And looks to me like that's definitely going to be the right
circumflex
area. Yeah, that will be, but maybe
not sure. It'll be a circumflex femoral.
Yeah. Let me go do a quick squirt here.
The technique that I used to use that a lot of people, it seems to have dropped. I don't know if it's because people think it's futile or they just don't know about it. But with the Terumo, it's sometimes I found in situations like this, you just let the Terumo do the work, which means you just spin it like mad as you move it back and forth.
You can do that.
And it'll find everything. At some point, it'll find everything.
I think that's where we want it to be. Get the sheath down a little. This is why also I really prefer to do, I actually do prefer to do the kissing balloon having the stent been deployed and then go over the wire that you had beyond it, just because I do find with the superas it can be hard to negotiate through their struts, just because You can see they're not always even.
Mm-hmm.
Since we saw it once, that usually means you can get it. And then you spend a couple more minutes on it.
That's looking
That's
promising.
one of them. Yeah, it was that other branch that kind
What
of
do you
went
get?
the other way. Exactly. So this catheter obviously is not going to go through those struts, but I wonder if that actually is going around it and then back in through the,
Yeah. Yeah. In the common
I'm
femoral.
going to spin it a little bit more.
This is just getting exciting, Kevin, but I have to hop.
Yeah, you hop. We're just
Send me a
about,
text.
we're
Let me
done.
know. Let me know
Yes,
what
I
you end up doing.
appreciate that. Yes, thank you.
Thank you
Good
very
luck.
much. Thanks. Have a
Yeah.
good day. Yeah. Good luck.
Bye-bye. We know exactly where the origin is. See, I think that's it. Fine. So what we're gonna do is give me a 2-0 balloon, please. 2-0 by 40. 014. Yeah. I just feel like it's the smart thing to do. We're not gonna stent through there. I got the wire. Yep. That was very helpful with the specs angle there with an 014. Yeah, that's perfect. And we'll just be able to balloon right there. It's think worth the slight extra effort to just ensure it. We'll do a 2-0, maybe then a 4-0, and done. Yeah. Let that wow, good. You see that, guys? We got it through. So we're gonna do let's balloon that there. Then Lori, I think we're gonna try a 4-0 after this. We have a 5-0. All right, here we go. This is going beautiful. Let's just go all the way up. This was a 2-0 that just made it. Yeah, go 10, 12, 14, 16. All right, take it down. So that picture. Now we did have to cover that profunda origin anyway. I mean, overall, that supera does look perfectly deployed. Okay, I'm no longer holding wire. Take a quick picture, make sure we're doing good. And then we'll go, let's try that 5. We'll see if we can get that in there because I think that's the right size. I think this is fantastic right here. I mean, you can really see. And then the question to me is going to be, is it going to clear better? And that's what I was looking for. All right, let's see if this will go through those struts. If not, we'll go 40 with a 4-0. Yep, it made it. Okay, why don't we go right here, please? Yeah, now again, I'm not worried about the struts going down on the cells. You see it's maybe slightly deforming that stent. Start out picture there. Let's hold it up for 30 seconds on this area here. And then if there's any issues with recoil or anything with that common femoral stent, we'll just re-balloon it. But I don't think that's going to be an issue. And we have the Celt. Yeah, you can open that. I'll take another 7.5 gloves, please. ChloraPrep if we don't have it. But remember, after this one run, we're going to go back in with the specs. I want to just take a really close look at that stent. That's just that one question there. Watching that, and if you see there, the stent goes back to the same size it was before. Okay, back this out, please. I really feel that that angle with the reflow is really like perfect. It's interesting though that sometimes you can put it, you can, make the angle going one way or the other. Most catheters you could be able to flip, but sometimes it can be difficult. But it was so stiff that we were able to get it. Now we're finishing up here. I remember what we'll do is we'll get that specs back down. I think that, oh wow, that's so interesting. That's looking great. And remember that distal to my superior in the SFA, that's a nothing. We looked at that. That's a nothing. Start that picture. This is a fantastic feature here that I didn't realize you could just de-zoom and you still get the whole picture. So I'm going to unwire that profunda. We're very happy with that result. We're going to rewire the common femoral through to the SFA and really take a quick look at that distal stent. Wire out. Yeah, we'll do this run here. We'll see. And then we can do our final runoff. Don't move. Yeah, what do you guys think? It's a funny little step off almost, and it's got that slowish flow. But I don't know. I'm not fully convinced. Give me a full zoom up on that stent there. So hard to know, and it's patent and it's good. No, right there, we said there's some small stenosis. I think we're gonna leave that. I think that we're gonna leave that. Less is more in this case because I think it's a common femoral. It's gonna be great for him. Okay, full dezoom. Let's do our final runoff, and we're done. We'll get the Benson, and yeah. Now before the flow was so sluggish, we couldn't even get any runoff. No moves. Let's see what he has here. Got mostly that nice big perineal and a little disease in the posterior tibial artery. Let's go to the foot. AT looks occluded, but he's now has real flow. No moves. All right, PT there. Like we had no flow before at all. That perineal actually reconstitutes through into that AT, which is diseased distally, but this is not pain at rest. No CLI here. All right, go back up, please. We are done. Up to the, oh yeah, it's great. This is gonna stay open for you and be really good. Zoom in on the hands while I'm doing the Celt because it's always a nice feature to see the closure that we choose. And yeah, look at that somewhat tortuous bifurcation there. And what we'll do now is take a quick look here. See, that's where my entrance is right there. We're happy with that. Back this out a little. One. Drag back. We're good, right? There you see a little bit of calcium that's there. Very comfortable with this device with that. Move it back and forth. We have the tension there. Oh, two. Yep, two snapped in just now. And good. Looks purse. No bleed, no wounds, nothing. We're all done, sir. Came out amazing. Came out amazing. You're gonna be really happy.